Hi, this is Alicia Bright. This is the last lecture of this semester. We're going to talk about cancer in parts 1 and 2, and then we're going to talk about evidence-based practice and a little bit about integrative health practices, which is one of my favorite subjects. So, background about cancer. Risk factors include age. Of course, it increases with age, although children and younger adults do develop cancer also. Smoking, of course, different nutritional factors, different carcinogens in the environment, ethnicity, and genetics play a role in this as well. In men, the most common causes of cancer are prostate, lung, and colorectal cancer, and in women, it's breast cancer, lung cancer, and colorectal cancer. Lung cancer is the most fatal, number one killer. About 28% of cancer patients are prostate cancer patients, 29% are breast cancer patients, 14% are lung cancer patients, and about 87% of these are from smoking, but there is a genetic kind of lung cancer that people can get. So don't assume your lung cancer patient has been smoking. Colorectal cancer accounts for about 9% of all cancers. So, as with any cancer or any disease, we want to prevent it if at all possible. And it's not entirely possible to prevent it, but we have found some things that are correlating with lower rates of cancer. So, of course, one of the things, the most important things to do is to reduce or avoid exposure to known or suspected carcinogens and cancer-promoting agents. So, cigarettes, don't smoke them. Excessive sun exposure, so use sunscreen. HPV, we now get vaccinated for HPV, but otherwise we can get screened for it. There are chemical carcinogens that we can be exposed to in the environment that we should avoid. A balanced diet with lots of fruits and vegetables, reduced dietary fat, reduced preservatives. Smoked and salt-cured meats contain high nitrate concentrations, so they should be avoided. Limit alcohol consumption. Participate in regular exercise. Did I ever tell you anything exercise is good for you? Maintain a healthy weight, adequate sleep, and stress management. So there's probably nothing really new here for you except the bit about avoiding specific carcinogens, smoked foods, cigarette smoke, excessive sun exposure, etc. So this is an acronym to help you remember the warning signs of cancer. The acronym is CAUTION US. So it's a change in bowel or bladder habits, a sore that does not heal, unusual bleeding or discharge, thickening or a lump in the breast or elsewhere, indigestion or difficulty in swallowing, obvious change in wart or mole, nagging cough or hoarseness, unexplained anemia, or sudden unexplained weight loss. So there are some terms I'd like you to be familiar with. First, in this picture, we see a normal cell that divides into two cells. This picture on the left, that little circle, is a happy little cell that divides into two happy little cells. And cells proliferate in this way, but then sometimes we have mutations. So a damaged cell would be surveilled by the immune system and induced to perform apoptosis or go through cell death. Cancer cells, on the other hand, the damaged cell survives and reproduces, and those damaged cells reproduce and reproduce. So proliferation means that there's rapid and uncontrolled division of cells. Differentiation means cells taking on a specialized function. So in a cancer cell, those cells don't differentiate well. So you may have plenty of cells growing in your liver, but if they're not differentiating right, they're not going to be functional liver cells. That's a tumor. Angiogenesis literally means building new blood vessels, and in this case, angiogenesis refers to the process by which cells make their own blood vessels to feed themselves. A benign tumor doesn't spread. The cell growth may be inappropriate, but it doesn't get too bad. Malignant, on the other hand, malignant cells are rapidly dividing cells, very poorly differentiated, and they can metastasize. And a metastasis, of course, means the spread of cancer throughout the body, taking up residence elsewhere. A neoplasm is just a term for any kind of new growth. Doesn't mean it's benign or malignant. Contact inhibition. Contact inhibition is the mechanism that controls proliferation in normal cells. In normal cells, if you need to repair a part of your body, the cells kind of know how many cells need to be reproduced in order to repair it properly, and they won't go beyond that amount. Without contact inhibition, the cells keep reproducing, and the tumor grows bigger and starts to press on other organs in the body. So, revisiting the cell cycle, you remember this from microbiology. I just want to refresh your memory about this. Remember that cells go through a process of DNA and RNA replication, mitochondrial division, and then cell division, and then there's a period of dormancy. And the reason I bring this up is to remind you about the cell cycle. Radiation therapy and chemotherapy attack the cell at different times during the cell cycle. Particularly, different chemotherapy agents attack the cell at different times. So, as we mentioned when we were talking about immunology and autoimmune problems, cancer is considered a deficiency of the immune system. Immunologic surveillance happens all the time in your body. You're always producing, your cells don't always reproduce properly. So you'll end up with little tiny cancer cells going around in your body all the time, but your immune system notices them, pegs them, and induces apoptosis and gets rid of them. What happens with immunologic escape is the tumor-associated antigens somehow disguise themselves, and the antibodies can't attach to them. So the cancer cell escapes surveillance and goes on and replicates. So the picture on the left here refers to the differentiation, and we're talking about grading tumors there. We talk about grading and staging tumors. Grading tumors is based on how well differentiated the cells are. Are they normal or are they abnormal cells? And on the right, we've got different stages of a tumor. Stage 0, or cancer in situ, is sort of, you could consider this a polyp, for instance, on a colonoscopy. So suppose somebody had a polyp on their colon. If it's not removed during colonoscopy and it's malignant, it starts spreading into the colon wall. You can see the first little dot there, the first little bump on the inside of the colon is not through the side of the colon wall. The second bump, stage 1, is starting to invade the side of the wall. Stage 2, it's starting to set up its lymphatic supply, a little bit of blood vessels. Stage 3, it's established all the way through the wall of the intestine, and it's established its own blood vessel supply. And stage 4, it's metastasizing. It's spreading out of the original tumor into the blood supply. So let's talk about metastasis just a little bit. The blue area in the picture up on the top left, that would be a primary tumor, and once it has established angiogenesis or established its own blood supply, then tumor cells can separate and move into the blood supply. They start traveling through the blood supply, and they can get caught up in organs that have a lot of blood flow through them, such as the lungs, the liver, and the brain. Those are the most common areas of metastasis. They can then adhere to the vessel walls and then extravasate or pass through the vessel wall. Then they can establish a new microenvironment, and establish its own angiogenesis, and that's how a tumor grows in a secondary place. So we would have a primary tumor arising in one part of the body, and then we'd have secondary tumors at the sites of metastasis throughout the body. So our goals of treatment are either to cure the cancer, that's our deal, or to do the best we can to control the cancer, or to just palliate or make the person as comfortable as possible without trying to actually cure them. The chart there is a continuum from diagnosis, where we're first, the goal is to hopefully cure it, or at least keep it under control, palliate it. When it's thought that we're not going to be able to help this person survive much longer, there could well be a referral to hospice. Hospice care really became popular with cancer care when we started to establish the hospice movement. It happened because cancer patients were demanding it. So there's hospice care. And then with hospice care, after the person's already passed on, there's death and bereavement care for the family. So we always remember that part of it as well. Palliative care, just to focus on this for a moment, let me just give a little plug here for a course that is given by the nursing department. If you haven't taken it yet, I highly recommend it. No one has ever said this course is not completely worth the time and energy. It's a course on palliative care and end-of-life care. And when we're doing this, we focus on the care of the patient, not the cure of the disease. We are supportive. We do symptom management. This is very interprofessional. It's very patient and family-centered, requires a lot of collaboration, and really we're focused on the quality of life versus the length of life. So goals of surgery are multiple, actually. We use surgery for a lot of different things. We use it in the diagnostic stage. There are some surgeries designed to prevent cancer, for instance. Angelina Jolie famously discovered that she had the gene for breast and ovarian cancer, and she went ahead and had her breasts and ovaries removed, making this procedure, giving the procedure some exposure and helping people to think about it. That's one way of preventing cancer, is removing the organ before it can cause you problems. We also would use surgery for clinical staging in order to figure out the best way to treat it. Of course, our ideal situation is if somebody has cancer, we could go in, take out the tumor, zip them up, and they're fine after that. But that's not always how it works. Sometimes we're just controlling the cancer like that. For instance, my mother had a brain tumor, and 3 times they were able to go in through the skull, remove part of the tumor. They couldn't get the whole thing without really messing her up. So they got part of the tumor and got back out of there. They did that 3 times, and each time she had about 18 months in between surgeries where she went back to functioning, if not completely normally. She was fairly normal. So that's an example of using surgery to control a tumor growth. We might also use this for supportive care, for instance, inserting feeding tubes, inserting a suprapubic catheter or a central line. And sometimes we use it for rehabilitation afterwards. For instance, if someone has had a mastectomy, we'll do a breast reconstruction surgery in order to give them the feeling of having a more normal body. The goals of chemotherapy can be classified the same way. There are some cancers that we're really pretty good at curing at this point. Burkitt's lymphoma, Wilms tumor, neuroblastoma are examples of tumors that we really have a pretty good handle on at this point. Other tumors, such as breast cancer, non-Hodgkin's lymphoma, small cell lung cancer, and ovarian cancer, we consider that we can control, but not probably completely cure those cancers at this point. It's a matter of controlling them. And then sometimes we give chemotherapy in an effort to palliate. to relieve pain and relieve obstruction. Chemotherapy can be given on an outpatient basis. It's typically given IV, although we can do oral chemotherapy also. It does hit the cell cycle in different places, depending on the drug that they're using. Chemotherapy is a specialty. You won't give it as a student. You may have the opportunity to observe, but chemotherapy requires special education and special precautions. Don't touch the stuff without special chemotherapy gloves. It requires extra education in order to handle it. This is why. Chemotherapy agents can be very toxic to normal cells as well as cancer cells. This is an example of an extravasation, an IV that leaked while someone was receiving chemotherapy and did terrible damage to this person's hand. Radiation therapy is one of the oldest non-surgical methods of cancer treatment. 50% of all cancer patients receive radiation therapy at some point or another in their treatment. And the goal is to shrink or eliminate the tumor. So chemotherapy is often done on an outpatient basis. It has some side effects associated with it. Radiation therapy has some side effects associated with it. Not only can it burn the skin around it, but it tends to burn rapidly divided cells and exhaust the person's energy levels and immune system. People can lose their hair, but more commonly, people develop stomatitis or inflamed mouth. The mucosa is a rapidly dividing cell normally, and so it's usually the first to kind of get wiped out and show signs of damage before it comes back. A film badge is something that's worn by anybody working in radiation. And ALARA is as low as reasonably acceptable. That's how much radiation we use. That's general principles of giving radiation. We don't want to use any more than we absolutely have to. And we don't want to expose anybody, workers as well as patients. We don't want to expose nurses to more radiation than we absolutely have to. So teletherapy is externally delivered radiation therapy. They beam radiation at a certain part of the body. The person will usually have some kind of a screen created that goes over their body where they're having the radiation and holds them very still and shows the person conducting the radiation therapy where to beam the therapy. This is usually done by a technician. Brachytherapy is when we put a bead of radioactive material inside or up against the tumor. This picture is one of somebody using a bronchoscope, doing a bronchoscopy, and using that fiber optic scope to place that little bead of radioactive material inside a lung tumor. We can also use it in other tumors in other parts of the body. Sometimes these seeds can get displaced. Patients are usually not considered radioactive, but you should check to see what kind of precautions may be required. This is a picture of dry desquamation, which is basically radiation burn. This is wet desquamation, which is a more severe case of desquamation. So what we do about this is we do very good skin care. These folks are obviously, this is painful, and there's drainage involved, and they're at risk for infection, increased risk of infection. So we do really good skin care. We might use normal saline compresses or a modified Burroughs solution, which is aluminum triacetate in an aqueous solution. We might also protect it with Vaseline petroleum gauze. So autologous stem cell transplants are another way of dealing with this, dealing with cancer. In this, we'll harvest the stem cells or the bone marrow from a patient with cancer. We'll give them chemotherapy to suppress their immune system, and then we treat the stem cells or the bone marrow with agents that destroy malignant cells without harming the normal ones. Then we re-inject the purified stem cells into the patient and hope that their immune systems come back. This is a very risky thing to do. You can imagine these people are on neutropenic precautions, which is also called reverse isolation. So we want to protect these patients from any pathogens we may be carrying into the room with them. So we carefully gown and glove to protect them. So we're going to talk more about the nursing care in part 2 of this presentation.